again, what I said earlier when I said what's going on here in Alabama and pullback going on everywhere in the country, certainly everywhere in the Southeast, is this difference in health outcomes for people of color. That brings us to the question of social determinants of health. This is a definition from the World Health Organization. Is this familiar to people in the room, social determinants? Are we in this conversation, kind of, sort of? The idea is that where I'm born, grow up, where I live, where I work, and my age is going to affect my health. And studies that say because of all kinds of issues we've started to talk about, that my socioeconomic status, my education, my neighborhood, the physical environment that I'm in, we didn't talk about any place yet where who lives near the dump? Who lives near the dump? Who lives somewhere in South Alabama where there's chemical plants making chemicals? And what the environmental, I'm guessing that the best real estate in South Alabama is not next to the chemical plant. I'm guessing the people that are downstream of the chemical plant are probably disproportionately poor, disproportionately economically disadvantaged. And so, just sort of thinking about, and Bill raised not only social support, but access to care, like how I get from here to there.
You know, Jim, a couple of years ago, you did a training for us on substance abuse, and talked about the pain medicine that was being dumped on in Alabama, and specifically in our coal mining communities.
Yeah.
And so, a long history of taking advantage of this group.
You bet.
And so.
Yeah, we see the problem of opiate use down the Appalachian Trail into North Alabama. We had a great woman come over from UAB, or no, she was here in town.
She was from mental health.
Yeah, who came down and talked about opiate substitution. But yeah, it certainly is a problem disproportionately affecting people who are poor, people who are rural, people who have lacked access. So the connection here between disparities and social determinants, the idea here is that health disparities exist when I have difficulty, when there's differences in the incidence, prevalence, mortality, and burden of disease. And I want to drive this home. As I said, here's a set of examples. This is an NIH paper on social determinants. Incredible disparity in Alabama, across the southeastern United States. African Americans disproportionately impacted by HIV. And that is about access and all sorts of other complicated issues. But last time I looked at the statistics, the prevalence by race ethnicity of HIV in Alabama was twice the general population statistics. I think I'm going to go on a ballpark, 30% of the population is African American, more than 60% of cases of HIV African American. That's true all across the southeastern U.S. That's Mississippi, that's definitely Alabama, it's definitely Georgia, it's definitely South Carolina. That disproportionate impact, most places twice the rate of the general population. Infant mortality among Alaska Natives, American Indians, look at that, 60% higher than European Americans. Obesity, rates of obesity for Hispanic children and adolescents. Heart disease, again, outcomes from heart disease. African Americans, 30% more likely. And again, as we talk about the reality for African Americans, poor outcomes from cardiovascular disease, diabetes, and some cancers. And so, you know, sort of as we're talking about, well, why get better at cultural competence? To me, this cuts right to what we as public health people are about. There's a direct connection from my way of thinking to growing as professionals and being willing to face up and say, we need to address these disparities, that these disparities are real. And what if we learned in COVID what's different and not different? There are people who would argue that COVID shined a light on health disparities, and that in many cases, a lot of studies that say the essential workers, people who had to keep going to work, couldn't go on Zoom, were disproportionately poor, people of color, working class. So this is a JAMA article early on. This is, I think, late 2020, But African Americans, more than 50% of COVID cases in Chicago, 70% of COVID deaths, and they were at that time 30% of the population of Chicago. Louisiana, there's a statistic there as well, 70% of deaths among African Americans. Michigan, 33%, 40% of death, even though black people were 14% of the population. Black counties in the U.S. What is the date here? I'm trying to look. It was late 2020. I don't have the specific date. It was an excellent article in JAMA. These figures did not change much as the epidemic progressed. But again, infection rate more than threefold. And death rate, again, COVID, like other chronic health problems, disproportionately affecting people of color, and higher prevalence and higher mortality. I went back recently as I was preparing for this. What was compelling was, well, let me put it out to people in the room, the worst, again, not hard numbers, but highest prevalence rates and highest mortality from COVID. What racial ethnic group? Anybody want to make a guess? Be brave, somebody. Nationally, the racial ethnic group that had highest rates, prevalence, and mortality from COVID-19. Come on.
Southeast Asians.
Southeast Asians, no. Black, no. American Indians, indigenous people. Way, way high, nearly 60% higher than Caucasian Americans. Again, by actual numbers, not as large, but the biggest impact. And again, if you think about the life of indigenous Americans, poor, rural, access, other chronic health conditions, higher rates of substance abuse, always higher rates of infant mortality. And here we are again, COVID sort of shining a lens on holding up a lens about what's not here. Outcomes for Americans of color, Latinx persons, various states, just higher rates of HIV among Latinx persons. You see the numbers, so I'm not going to read numbers to you. Just a note, Hispanic, Latino, Latina have been debated. I think the preferred language to talk about people is Latinx, which is more inclusive. So if this isn't familiar to people, its language, I've been told, is preferred. Another illustration, I just put it out in terms of what's going on in America, is what happened early on. I don't know if anybody remembers this, but in the spring and summer of 2020, if you were tracking national cases, there'd be these weird bubbles in the middle of rural nowhere, of clusters of COVID. You know, we saw New York City, we saw Seattle, we saw Atlanta, we saw Miami. All of a sudden, we're down here in Smithfield, North Carolina. And I'm looking, what's up with the hotspot? The language CDC was using was hotspot. What's going on in Smithfield, North Carolina? I hope Smithfield hams don't sue me because they got a lot of money and plenty of lawyers, but I'm just telling you what the facts are. Smithfield, North Carolina was a pork processing plant. And what happened in a number of these hotspots was that there were food processing people, which are disproportionately immigrants, always less educated. Again, we used to think of poor white people then Latinx persons, increasingly Asians and African immigrants, now slicing our bacon and chopping up our chicken breast, but 40% foreign born. Historically, always difficult work environments. Poor history for workplace history. There's a 1920s novel by Sinclair Lewis. Mm-hmm. It'll come to me. Google it. Everybody got their pull out your smartphone if you're curious.
Jungle? The Jungle?
Something Jungle, yeah. Is it just The Jungle?
I think so.
Yeah, Bill got it, Jungle. That documented the 1920s, an awful work condition. It hadn't changed that much. Pressure to produce and do more. I saw pictures in the news they saw these outbreaks. They saw people falling over on our bacon while they were trying to work, and they kept them working 12-hour days and whatever else in these cold, wet environments. And I saw pictures where they put a sheet of cardboard up between workers. So I'm chopping bacon here, she's over there, and somebody taped up a piece of cardboard as the PPE to keep me from getting COVID. That was the strategy. There's your average wage, North Carolina wage, $13.74. I looked up Alabama wage. It's just about the highest median wage in this field is about $15, almost $16. So again, this was September 2020, but I look at this and I think, well, yes, I like bacon on a biscuit. I got to tell you, I love bacon on a biscuit, and I like pork chops. But what happened is we said these people can't go home because we like bacon on our biscuit and because we need pork chops. And we're willing to, somebody somewhere kind of said maybe we're not going to look that hard at safety conditions. 150 of the largest meat processing plants were in the top 25% of U.S. counties for coronavirus. So again, we'd expect Birmingham, we'd expect Atlanta, we'd expect Chicago, whatever else. We were not expecting these teeny little whatever else. 3,500, this was September, 3,500 confirmed cases, 17 individuals died. This was early on. A plant in South Dakota. Boy, I'm going to get sued. Well, I may end up in jail. Well, I guess it's just a fact. How can you sue somebody who's just giving you the facts? 900 COVID-19 cases in a plant with 3,000 employees. So it's the work condition, and then it's also the living conditions. Anytime you've got workers in this kind of low wage kind of stuff, it's 8 to a room and bunked on top of each other, and there's no social distancing. Please.
Just to tag on to that, here in Alabama, we work real closely with our chicken plants.
The same thing.
Alabama is one of the largest chicken processors in the nation, and so that was a issue that we worked through, and some of our vaccination clinics were specific to those areas to try to help.
Yeah, but higher prevalence of COVID in those places,
Definitely.
Bill? Yeah.
Yes,
absolutely.
It's the closeness of the working.
You bet. Closeness of the work, ways that people live, the fact that the work could not be done social distance. There just wasn't enough PPE for people to do that safely. And there you are. So I looked at, this was a recent study, I think this came out in April, that just kind of looked at who died. I think it's who died in the first year. But again, it sort of speaks to all of us about health, about social determinants of health, death rate, and again, how social determinants of health affected the outcome of COVID. The death rate of lower socioeconomic position adults, didn't go beyond high school, 5 times that of higher socioeconomic level adults, 5 times higher mortality rate, 2 times higher intermediate social income. White women made up the largest percent of higher socioeconomic positions. By comparison, 60% of Hispanic men were lower socioeconomic. So that's sort of how it went. But what we saw, and think about it, who was still working in March, April, May? What were their working conditions? Did they have access to PPE? Again, I'm glad there was chicken in my grocery store in April of that year. And at some level, I say, as a social worker, as someone who's concerned about issues of social justice, where was access to PPE? Where was access to good information? We didn't have a vaccine then. And again, I'm glad to hear ADPH was part of offering immunization early on. There's a lot of people for whom that wasn't true in essential industries. Death rate among Hispanic men, 27 times higher than high socioeconomic white women. And among all 25 to 64-year-old adults, about 1/3 accounted for 2/3 of COVID deaths within that age group. So this study, looking back at death rates, just reminds us about the reality of social determinants of health and the reality of privilege. And this quote was in the JAMA article. This gentleman is faculty at the University of Chicago, physician, I think a cardiologist at the University of Chicago, but in the editorial that started that JAMA article that I referred to earlier, he talked about privilege, and I used that term earlier. This last line stuck with me. Consider the aggregate burden of at-risk comorbidities to COVID, the effects of social determinants of health, and the absence of privilege is how we ended up with that impact of COVID and the connection between social determinants. I like this slide because sometimes I get this and I say, what can I do about it? How can I, people say, oh, fix poverty, fix whatever else. Like, oh, I'm not sure I can do that thing. I think what I like about this, if you look at those blue circles, if you go from right to left, what you see is the things on the right are things that good case management, good health care, good individual level interventions can affect. We can prevent disease and prevent injury. We can, in our individual interactions, individual level interventions, we can impact risk behaviors. We can check for lead paint. We can do the things that we do. And so it's not the solution to poverty. It's not addressing all inequities. But what I like about this is it says we can all be part of the solution. There in the middle, we look at living conditions, and maybe I can't change that, but can I be part of coalition? We've got important public health coalitions and partnerships where we are working on healthier food programs, where we're working on, is there a walking trail in this community, where we are advocating for alleviating lead paint in particular places. And so we go from those individual level to the sort of community level interventions. And as we keep going about institutional inequities, there are strategic partnerships we can be part of. That is public health partnering with the Department of Education to improve access to health in school settings. We can look at various partnerships, public-private partnerships, where public health works with whoever to get access to healthier foods, again, access to recreation, and eventually we may be able to impact these health equities. Again, I think it's easy to kind of say, what can I do about it? But what I think about is what we can obviously affect in our individual level practice, and how can we advocate at the county health department level, at our church, in our civic groups. We've got examples all over Alabama of people saying, maybe we're not going to solve poverty, but we're going to partner with people. We're going to join coalitions. We're going to get fruits and vegetables. We're going to do a community garden. We're public health. Somebody's got a plot of land out behind the county health department. We're going to develop a community garden so access to fresh fruits and vegetables is accessible to people in our community. And then eventually, maybe we can impact health determinants. Comments here in the room? Questions here? Letitia, anything I've said that's wrong so far today? Point out all the mistakes I've made so far today.
I haven't.
You don't? I know I made some. Anybody, what am I doing wrong? Anybody want to add or ask anything? Bill, any questions coming over the...
None so far.
Okay, no worries. Everybody, if you are watching this on video conference, your questions are welcome, your comments are welcome, and it's a phone number that you can call in as well. So I'm going to brag on my home state here. Let me just go. I'm going to brag on North Carolina, everybody. So North Carolina Medicaid, several years ago, our health director at the time, medical director at the time, said social determinants are affecting the health of Medicaid recipients, and we need to be addressing those. And so what she said, if you look at the scheme at the top, it says the neighborhoods and the built environment. Neighborhoods means where I live, but the built environment means, are there sidewalks? Means, are there playgrounds? Is there access to recreation? Built environment, as I read it, really has a lot to do with health and physical activity. And so what neighborhood am I in, what were the environmental things, and there's hard studies that say if you put bike trails and walking trails in, people are going to get healthier. And if I don't have a place to walk or ride my bike, it's not safe. The built environment works against physical activity and makes it harder. Health care and access to health, social and community context. So in other words, part of what determines my health is, am I in a cohesive community? Am I involved with social organizations? What about education? As we think about the education system and the collaboration, I've got examples of Alabama of innovative, important collaborations between public health and education. Bill talked about some of that. Where that doesn't exist, where the education system isn't involved in promoting health, we see the opposite. And then obviously economic stability, where people have stable economic circumstances, they are more likely to obtain and sustain health. Again, these things promote health. And so what we've done in North Carolina is Dr. Cohen said, you know what, let everybody who provides case management services to people with Medicaid going to ask certain questions. And so it is required. You know it's required, Kelly. I'm looking. You know it's required because the EHR won't let you move on to the next screen until you do it. Does that make sense? A requirement included, not just a requirement, but the EHR will, the electronic health record will lock up until you say, I want to know about whether or not you've got access to healthy food, stable. Do you have access to food? Are you hungry? The question on the screener, and there's a link there. Screeners actually, have you been hungry, gone to bed hungry, somebody in your house gone to bed? It's very interesting. It's sort of an interesting way to ask about what about access to food? Do you have stable housing? Is transportation a problem? And then is there a threat of violence? And again, look at the screener there. The screener is much more eloquent than I am, but every provider doing intake for every Medicaid person in Medicaid case management, not every physician, everybody, but if you're getting case management services in North Carolina through Medicaid, you're asked 4 questions to assess these. And then there are always questions about depression, substance use, tobacco, diet, exercise that are expected to be part of just good health care. So what the system says is, hey, if you're doing a good history and physical, if you're doing a good intake, you're asking those things. But in addition to those, you are prompted to ask about food, about housing, about transportation, and about whether or not the threat of violence in your home exists. And there's a model that the North Carolina system puts forward. Again, not brain surgery, social, economic, emotional, financial well-being, environmental well-being, physical well-being, intellectual, and spiritual well-being. So the model that they're inviting people to move towards is one of whole person care, the whole person care model. Last slide should have been, it's not there, but what they've done in the Medicaid system is they are referring people to a web-based system of resources that's been developed and maintained by county. Let me back up and show you. So in other words, what it does is it says to the frontline caseworker, I've got food insecurity, I'm here in Buncombe County, and the web system, NC Cares 360, leads you to a web-based thing where I'm going to say, here are the food resources in that county. And again, they've had a huge financial investment. I mean, think about it, to not only get the system changed up to do this, but to get a web-based system of resources that someone made and maintained, but across the state. If I say housing not stable in this county, it's populated with a list of the housing providers in that county. And so I think what's important is it's not only asking these questions, it's equipping frontline public health people with the tools they need to address those, to give them some practical help about that. Questions about the system? I'm not just doing a commercial for the state of North Carolina, but I think the idea that, again, back to that, what we can do in our individual practice, are we asking these questions, are we doing the work to make sure those needs are met, is really something for all of us to look at. So the last thing I wanted to do today was to think a bit about the organizational level. So we sort of have touched on the ways we as individual nurses and social workers grow in terms of responding to diversity. We talked about sort of the intended impact and how we hope it's going to affect public health well-being, or hope it's going to affect health seeking and health care. The last portion of what I wanted to do was to talk about making organizations more culturally competent, enhancing diversity, equity, and inclusion. Let me sort of ask the group here by way of beginning, why would it be important that we ask these questions of the organizational level? Is this organization a culturally competent organization? What does that mean? What would that look like? Why is understanding the cultural competence of the entire organization part of this conversation? Any ideas?
It gives you an overview maybe of gaps in services.
Absolutely. Part of what it's going to do, it's going to invite us to look at service delivery and say, how are we doing? Why else is it important to examine the organization and the leadership and the policies? I'm going to go out on a limb and say, I wonder how, as a frontline nurse social worker in that organization, how it would be easier if the principles and values and behaviors of a diversity supporting agency were modeled at the top level. And I guess to just name it, how many frontline social workers, how many frontline nurses are working in places where the entire leadership team is white men, where the entire most of the board of directors is mostly male and mostly white? Does the leadership, I mean, the first starting point is, does the leadership of an organization look like the worker bees? Does the leadership of an organization look like the clients that we serve? Some places, I think the answer is yes. I'm going to go out on a limb and say I imagine there's some organizations in Alabama, I imagine there's some county health departments where the leadership and the management doesn't reflect who we're serving, and I just think we've got to ask the questions, are we providing culturally competent services if there's a disconnect between the organizations and the people we're serving? Am I crazy? You're not going to say it out loud. Anyway, what do organizations do? I think they do the hard work of thinking about. It's the same steps we talked about earlier. It's doing the work, the hard work of self-analysis. When we talked about the individual nurse or social worker, it says I'm going to do some honest assessment of how we're doing as an organization. I'm going to ask some hard questions, not only of people who like me, who worship where I worship, who look like me, who think like me. I'm going to ask our hard questions of critics, of people that don't look like me, of people who might help me grow. And then I'm going to learn from that, and this shift can be sort of the same thing. I'm going to get, after I do the self-reflection, I'm going to gather information and knowledge, and then I'm going to try to apply that so that, in this case, not just culturally competent services, but a more culturally competent organization emerges. Question, Bill? I say nothing came in.
Well, going back, we were talking about
Please.
Communities.
Sure.
Rhonda Holland has sent in a message.
I know her.
Alabama's cancer program has a shade structure grant for schools and communities with little to no access to community parks.
Great, great.
So, and I know our health disparities grant, we're also working on exercise areas, parks and things where people can get in communities.
Yeah. Back to that idea of built environment. We say, well, what does that have to do? Why is Rhonda lugging turnips and fresh sweet potatoes around to people? That built environment is enormous. And we talk about chronic disease. We're talking about diabetes. We're talking about hypertension. We're talking about heart disease. If you look downstream, if we get people more active, if we build on programs like the SHADE program, did I get it right? The SHADE program, where we are going to have individuals learning physical activity, the advantage of not saying, hey, turn off the screen and do whatever, but actually being part of enhancing parks, building parks, walking trails, biking trails, that all of that, particularly with young people. And back to the idea of partnership, partnering with education to say, hey, public health, we did a grant for 2 nickels. Education, you got 2 more nickels. Let's go together and enhance the park to, let's use your playground on off times, whatever we can do. But doing that early on to get those habits entrenched early on. Again, health outcomes where the built environment promotes physical activity. There's a direct connection between less diabetes, less heart disease, less hypertension, which I'm sure is why the Wise Woman program is involved. And they know that connection. They are about managing those lifestyle changes. Rhonda Holland's a smart person. Somebody ought to hire her and bring her up here into the big house. Defining diversity. I said the language of helping organizations grow, diversity, equity, and inclusion. Just some language here, defining diversity. If you are promoting a more diverse organization, that starts with the presence of differences in your team, in your leadership team, in the leadership structure. And the question becomes, are you addressing populations that have historically been underrepresented and marginalized in your organization as you move forward? If your organization is to grow into the 21st century, be the kind of organization that we can say is truly supporting issues of social justice and addressing health and equity, that you are doing the things to make sure people who've been underrepresented are part of it. Equity, the second pillar of culturally competent organizations, is about promoting justice. And again, back to the values of social workers, back to the values of nurses: justice, impartiality, fairness, and willingness to look at the root causes of those disparities and say, again, back to that model of how we address those, that continuum from the Kaiser Family Foundation. I'm not sure I can address things on the left-hand side, but I can think about how I'm interacting at the one-on-one level. I can work within my organization, and I can partner with other organizations to grow in terms of addressing social justice and fairness, and try to do what I can. Inclusion. These definitions are from a USDA of all the places. USDA is a wonderful set of materials that I've adapted on diversity, equity, and inclusion. And again, if I'm moving my organization in a way that addresses these unmet needs, that addresses social justice, I'm working towards ensuring that those who are diverse feel and or are welcomed. And so again, we sort of talk about how organizations grow in terms of their diversity, equity, and inclusion, and ultimately, it's not just sort of we're providing services to you, but the idea that there's a full participation in the decision-making processes, that people who are represented, who've been historically not brought to the table, are actually given an opportunity to participate in the development process. So why? What makes it tough? I mean, I think the history of we've been doing frontline worker bee cultural competence training my whole career, which is many years. I don't know many places that have asked the question, how is the organization doing? And so this idea that initiatives around diversity and equity and inclusion are fairly new is important. Like, well, what would that mean, and what does that look like? And third bullet feels important. I think it's true. Leadership lacks diversity in gender and ethnic diversity. And I am a white male, and so I'll say it. We inherently bring privilege as white men to this conversation, and we are disproportionately in positions of leadership across public health, across social services, and that part of making organizations look like us is just making sure that people of color, people who are not European American, and females have a chance to rise to positions of senior levels. I don't know the answer, but as I'm saying that, I'm smiling, thinking, well, yes, there are certainly people in positions of leadership, and who's running what percent of county health departments in the great state of Alabama are being run by European American males. I don't have the number. I think it doesn't look like the people in the waiting room would be my hunch. Kelly, you want to comment? Kelly don't want to comment. Thank you. I'm asking the question. A lack of support at the senior leadership sometimes is lacking. And how we measure this, how we measure organizations becoming more culturally competent is challenging. There aren't metrics or sort of what would that look like. You know, sir, we know it when it's not there. And I guess let me back up and just say there's no ill will about the people running county health departments. We're going to get emails, Bill. You're going to get emails today. I just think I wouldn't be doing my job if I didn't say that addressing social justice, that addressing diversity has to involve asking these hard questions. Does the people running county health departments look like people in the lobby? So what's the value? Why even ask these questions? Well, first we're going to tap into people's real potential. We've got unmet potential that's not being met if we aren't striving towards that. What's the bottom line? Somebody always wants to know the economic bottom line. This is again from the USDA publication I talked about. Better revenue, more customers, and higher profits. I can't say that comes from the public health world, but I don't know anybody running a health department that wouldn't say, I'd like to see more sales, more customers, and higher revenue. And so maybe if we push that. What about employee engagement? And I do think that studies have shown, again, this is from that USDA publication I talked about, that studies have shown that people are happier to work in places that are more diverse. And so what that gets to, and Bill, you've talked about this several times, staff retention. And keeping people on board. You know, people say, I'm losing this nurse. These nurses all want to fly out to Akron and make some real money, or these social workers are hopping back and forth to DHR and back. Well, how are you doing at creating a diverse and inclusive workplace? And maybe that's going to have something to do with staff retention. More likely to understand the consumers with whom you're working. In this case, the language is target customers. I think we don't usually use the term target customers, but maybe we should start to think about public health like a for-profit business. And then again, that bottom line is about revenue. So what do we do about it? What do organizations do about it? How do we get better? The first concept for us to get is sort of, let's look at implicit bias. This is the unconscious ways that we make assumptions and we sort of project onto situations, our old ideas. And so kind of as we look at not acting on bias about age and gender and race, ethnicity, and people who don't speak English as their first language, we've all got stuff. I mean, what I really find kind of troubling is people that want this journey to sound easy. People say, well, I went to a 1-hour cultural competence workshop, and I got a handout where they said, all lesbians want you to do this, all Chinese people want you to do that. I said, you cannot put people on one handout, and if you think you got all the answers in 1 hour of a webinar, I'm 30 plus years into my social work career, I still haven't figured it out. And so I think it's this business of examining our bias, of being mindful and not acting on any implicit bias. And again, I just challenge anybody. I don't think anybody ever finishes this work. And I just think that we've got stuff to work on. And it continues into, 30 years into our nursing social work. Understanding what it would be like for others to stereotype you, and sort of back to what we talked about, stepping into people's shoes and recognize, wow, these are humans and more like me than more different. And then learning to slow yourself down. Talking about characteristics, watching our language and making sure our language is inclusive. If we're not sure about what people of different colors, class, social, trying to find language that is inclusive, and I say always following our customers' leads about language, asking people what language they'd prefer. Back to the issue of gender that Cindy raised, it's like, well, he, she, the sign-in sheet said Bruce, but that doesn't look like Bruce waiting. My name is Cindy. What shall I call you? Asking people their preferred pronouns as an example of ways to sort of work around that difference and make sure we're doing things that are our practices inclusive. Looking at whether everything that we do within the workplace, our policies, are fair. And then that last reminder, I think this is a lifelong process. And as we talk about our own work, it never stops. Even if I've been in the business a long time. So one of the other ways that we get better is we sort of not only watch our bias, but we watch subtle ways in which we do what are called microaggressions. Microaggressions are kind of defined as those ways we act on bias or prejudice that we're not aware of, that come out in little ways. Bill talked about learning by reading social media, blogs, essays, sort of even before you get to work, I'm going to do my work. I know I'm working with this population, or I know the people in my workplace come from this religious background, or I know I've got people with certain disabilities. I'm going to do my work, watch documentaries, do other things. Be willing to have the conversation, but to be realistic about those. To say, is it all up to this person to educate me? What would that conversation look like? And then the last bullet just says kind of consistently developing our awareness. If we're aware, the example I always give, and I can do this again because I'm male, is men talking over women in meetings. I've got 5 women and 2 men in this room, and I'm guessing some of the women know exactly what I'm talking about, where someone is making a point and the dude is going to cut you off or whatever else. And I just, it is about power and imbalance, and it's about maybe ways that we're socialized around gender, but I just, that kind of, what is it, mansplaining and talking over people. I'm smiling because I just had a very difficult, we were all on a webinar, and I called this dude out. I was like, I almost said his first name, Mr. X, because I don't want to say his first name. Mr. X, she wasn't done. Like, we're all professionals, but it was just, he's so smart and he's so whatever, and he's male and he's white and he has privilege and he's in an academic thing. And I just thought, you know what, I'm going to call out. I said, dude, she wasn't done. I was nice about it, but I stopped what we were doing and I said, she wasn't finished with her thought. And it was like, afterwards I apologized to him. It's like, I didn't mean to be rude, but I felt like that's a way that we say, no, she doesn't deserve to be cut off by you. So again, social justice, back to what we talked about, the view that everyone deserves equality. Again, why are we here? The whole point of looking at these macro level issues, social justice. That bald white guy had a lot to say today. Questions? Let me start in the room. Anything you want to add to the conversation we've had today? Anything you want to challenge? Anything unfinished for people here in the room? Anything you want to take a highlight or two, or any questions I haven't answered?
Jim, a couple
Please.
of things that
Please.
I wrote down,
Please.
and as you were talking, valuing people, valuing their opinions, I think was the biggest thing I kept hearing.
And again, it's the way we get over us and them, Bill. That if we're in a us them thing, there's something inherent that about my not valuing you. But once we sort of reinforce, and it's back to second or third slide, the inherent value of people, both in nursing and social work ethics, say we embrace the value of people, we're going to overcome that. But if we're not going to come from us them, but it's something about valuing the individual, the client we're working with, valuing our coworkers, as a leadership team, valuing the diverse employees that we supervise, the diverse people in our constituent group.
And then the other thing I wrote had to do with power and control and willingness to giving up that power and control by saying, I want somebody that's different in this position, or in on this board, or representation, or and so that's difficult. You see it in small town, you see it in corporation, you see it in every organization we are. Am I willing to give up a little bit of power to have some diversity and to have a differing opinion?
And thank you, Bill. I think it's human nature. We surround ourselves with people like us. I did a training years ago and was some kind of, I don't know, team building something. But this woman, I did a Myers-Briggs thing. This woman had hired other white women that looked just like her, whose values were just like her, and I kept doing these activities. Well, what does everybody think? They, as a group, went with Mama, and as a group, went with Mama over here. And so there is a way that people that think like us, look like us, worship where we worship, that's familiar. But again, we grow as individuals when we challenge that, when we say it's time for somebody else to take a seat at the table. And again, that hard question, do the people in the boardroom, do the people at the leadership level look like the people in the parking lot, look like the people in your lobby? And if the answer is no, I think it comes back to service delivery, and it comes back to public health values. Anyway, I think I got to thank everybody. I think I'm done. Am I done? Oh, resources. Oh, you thought Jim was so smart. Oh, Jim's so smart. Jim was so smart. He stole from all these websites. Look at that. Boy, he is smart enough to steal from some good people. Anyway, thanks to I almost said the guys in the booth, the guys and the women who are running the video conference group, Anna's here, to the Alabama Wise Woman program that's provided support, to you guys for coming. Bill, as always, for your help with the CEs and your friendship all these years, and you're making this happen. I'm grateful to everybody. Thank you all here. Thanks to those who took an hour and a half, either from your live day or from your archive day. I know I've asked some hard questions, and I'm really grateful that people took a minute to think about these things. I'm grateful always to be here. So with that, I think Bill's going to close this out.
I am. Thank you again, Jim. That was awesome. The great thing about this program is that the guys in the studio here are going to put this on the internet, and we'll be able to go back and watch it again. And there's some information I want to review, and so thank you for that. And those of you who are watching, please know that that's going to be available in the next couple of days. This concludes our program for today. Again, thank you, Jim, for being here, and thank y'all for watching. Again, you can go to our website and find that information, and please make sure to send in your continuing education information if you want CEUs.